the AOI Telangana state. Thank you very much. Please
Thank you.
continue.
Yeah, let me just put my. Can you see my slides?
Not yeah. Yeah. Yes, sir. Yes, Kishore.
Okay, so let me start. Can you see my first slide?
Yeah.
All right. Good evening, everybody. At the outset, let me thank the Telangana chapter of AOI for this wonderful initiative. I've been following all the proceedings on this particular banner, and hats off to the organizing committee. Without further delay, let me introduce myself. My name is Srinivas Kishore, and I'm now the Director of ENT Services at AIG Hospitals, Hyderabad. And I have a special interest in the management of obstructive sleep apnea. The topic that I've been asked to speak today is a very basic topic, and it would cover right from history through evaluation, and also a couple of case scenarios that I've brought in that will sort of try to help us achieve a decision when we look at certain patients. So each one of these case scenarios is a particular phenotype in its presentation. So the title of my topic is the functional assessment of the upper airway in sleep-related breathing disorders. The reason why I said sleep-related breathing disorders is because this is a big, broad heading. There are lots of sleep-related breathing disorders, and all of them we'll be discussing today. I have nothing to disclose. So I would like to start my presentation with a particular video. Are you able to hear the sound?
Yeah, yes, Kishore.
Yeah. Look at the facial grimace. Observe the open mouth view. Observe that this patient has stopped breathing. Look at this saturation. Look at the effort that he is doing, and look at the patient. Now, this kind of patient, this is a clear patient. How is he different? He's not very fat, but if you look at his architecture of his jaw, it tells us that it's a very skeletal kind of patient. The earlier patient also has sleep apnea. This patient also has sleep apnea. So if you really broadly divide patients, these two patients are at two ends of the spectrum. And there are lots of patients who fit into, who are in between these two patients. That means the obese variety with thick tongues, thick palates, thick oropharyngeal structures, and patients who are very thin in their phenotype, but still have obstructive sleep apnea. Now, sleep-related breathing disorders is a spectrum of diseases ranging from primary snoring, upper airway resistance syndrome, obstructive sleep apnea, and obesity hyperventilation syndrome. These basic four diseases encompass what we call as sleep-related breathing disorders. Now, are all of them the same? No, they're not same, and each one of them are different by certain parameters. Now, what are these parameters? They are separated by snoring, having repeated arousals, having desaturations, and having type 2 respiratory failure. Now, let's see primary snoring. If a patient has primary snoring, he only has snoring as a symptom. That means he's only an annoyance to his sleeping partner or his bed partner or his flatmates. but he is not causing any harm to himself in terms of repeated arousals. He is not desaturating, and he or her do not have any kind of respiratory failure in terms of CO2 retention in the body. What is upper airway resistance syndrome? Upper airway resistance syndrome is different from primary snoring in the sense that the patient also have snoring. They do not have desaturations or type 2 respiratory failure, but what they have and what differentiates them from primary snoring is repeated arousals. So, upper airway resistance syndromes have repeated arousals because they have increased work of breathing. That means they need to put in little more effort to breathe, and this increased effort that these patients put in will cause sleep fragmentation. And these patients have only one basic symptom, which is EDS, or also called as excessive daytime sleepiness and fatigue. They do not have any other symptoms caused because of repeated desaturations or type 2 respiratory failure. The next disease in the spectrum of sleep-related breathing disorder is called OSAS, or obstructive sleep apnea syndrome, or obstructive sleep apnea hypopnea syndrome. Here, the patients have snoring, have repeated arousals, have oxygen desaturations, but they do not have CO2 retention in the body. The next in line is obesity hyperventilation syndrome. This is the extreme right of the obstructive of the sleep-related breathing disorder, and it's an S all over. These patients have snoring, these patients have repeated arousals, these patients have desaturations, and these patients have CO2 retention causing type 2 respiratory failure. Now, if primary snoring is at one end, obesity hyperventilation syndrome is another end. So when you treat patients with obstructive sleep apnea, you need to differentiate them from obesity hyperventilation syndrome by a test called ABG, wherein you would be able to identify whether the patient is having CO2 retention and his PCO2 is high or no. How you have to go about managing these patients differently, we will talk in the subsequent slides. Now, it is estimated that the average lifespan of an untreated OSA patient is 58 years, which is 20 years shorter than the average lifespan of general population. This is the impact that this condition is having on an individual's life. If you look at the epidemiological studies and you compare the prevalence of obstructive sleep apnea, if you compare it to the US or Australia or India or China or Korea, we stand quite high in terms of prevalence. And this study is basically done from a very high institute, from Johns Hopkins. And this data is staggering to tell us that we have one of the highest prevalences of obstructive sleep apnea, not only in men, look at in women. We trump other countries in the incident prevalence of obstructive sleep apnea, even in women. Now, there are many, reasons why, even though our BMI is low, our incidence of sleep apnea is very high, and our biggest problem is central obesity. Well, that's a different topic. Now, why are we even treating this condition? WHO has basically labeled obstructive sleep apnea as the disease of the 21st century, because this is one condition that can actually affect and cause so many conditions, including a staggering high rate of nighttime heart attacks of about 91%. If you look at the number of papers that are published in PubMed, and you will basically see the numbers of papers just continuously going higher and higher, just being 2020 being low because of COVID years and COVID getting an importance over obstructive sleep apnea. And that is the kind of importance that people are giving to obstructive sleep apnea nowadays. and compare it to chronic sinusitis. This is just as a comparison. Look at the papers that are published in chronic sinusitis. They are just very few in number compared to obstructive sleep apnea. So if you just type management of obstructive sleep apnea, what is the gold standard treatment of obstructive sleep apnea? The gold standard for obstructive sleep apnea is CPAP, and this is the answer that Google gives you. But the problem with managing obstructive sleep apnea with CPAP, even though it is gold standard, and we all agree hands down that it is the gold standard therapy, the reason being compliance, compliance, compliance. The moment you advise a patient to use CPAP, he may agree with you that, yes, sir, I will use it since out of respect to you or out of the kind of explanation that you've given him about obstructive sleep apnea and the impact that it's having on his quality of life and the effect that it can have on the other diseases. Even though the patient sort of accepts it on the face value, the problem is the acceptance does not stay for very long. See, this is an inherent human behavior, whether it is a thyroid tablet or an anti-allergic tablet or CPAP. If you ask somebody to use it regularly, they don't want to use it. Plus, the added taboo that comes with the fact that you are attaching a particular device onto your face, and it is an inconvenience to the face as well. So it comes with a myriad of problems, not only in terms of long-term compliance, but in terms of air leaks, stomach bloating, problems when you wear the nasal mask, so on and so forth. Now, if you ask this lady patient of mine, why do you have the third bindi? She would say that you have given me this third bindi, sir. I have not put it. This is nothing but pressure necrosis on the nose caused by the sheer presence of the mask. Why is the mask put in so tightly? In the preliminary report that the CPAP gives us, which is the compliance report, if the leak happens to be very high, what do we do as people treating sleep apnea? We ask the patient to put the mask more tightly. We tell them to harness it tightly. And the mask becomes so tight that it causes a pressure necrosis no matter what quality of mask you basically use. Now, why is the pressure so high? Why is the leak so high? There are many, many ways that basically tell us that the pressure is high because of static or dynamic obstructions that the CPAP is not able to overcome. Well, that's another particular topic. But the basic point is that patients have bad CPAP compliance. Now, if those are patients of one kind of patients who basically have problems because of their inherent inability to use it, because of inability to put on the mask, or because they have obstructions in the nose or obstructions somewhere in the throat, or they're having bloating sensations, there are a particular set of patients where there are absolute anatomical structural problems causing them to fail the CPAP. That means they're not able to wear the CPAP. These kind of patients having epiglottic collapse, the moment they come back to you and say, doctor, what kind of a death trap have you given me? The moment you put on this mask, there is a draft of air coming and hitting the valvula, completely closing the laryngeal inlet. And that is the reason why these patients fail CPAP. Now, whatever the reason might be, you as an ENT surgeon are actually poised to deal with these patients who are failed CPAP either because of structural problems or unable to use the CPAP or will not use the CPAP for various reasons. Now, like this particular gentleman here, a person who is very confused as to, because the gold standard treatment has failed, you have many doors and you don't know what door to open for which patient. Now, if this is how you're confused, because you need to give what is the second best treatment that is available for this particular patient. Because you failed the patient has failed the gold standard treatment, you have to devise a way to open the right door for the right patient. Now, why do we have so many doors? Why don't we just operate all these patients? Why should we even think so much? Why is it that ENT surgeons are so confused to give your particular patient the right door to open? That is because history has told us otherwise. If you are a patient in the 60s or 70s or early 80s and had a diagnosis of obstructive sleep apnea and snoring, our senior colleagues were offering this horrific procedure called uvulo-palatopharyngoplasty. Of course, this has taken a quantum leap in terms of what we do and what we call as uvulo-palatopharyngoplasty. But anyway, we were given one treatment called uvulo-palatopharyngoplasty, and you'd be surprised, at that time, CPAP was not even there. So every patient that walked into an ENT's door was offered uvulo-palatopharyngoplasty. But over a period of time, like any procedure that is given continuously, has to be introspect. And once the procedure introspected, the outcome was bad. All the patients who received uvulo-palatopharyngoplasty got bad success rates of about 40%. So if you offer a 40% success rate to your patient is going to laugh and you said, "Doctor, you think I'm crazy to come to you to offer that kind of a minimal success rate? I will think of other ways and means to come out of this particular problem." So ENT surgeons back in that day were poised with this particular number and hence gave us a very bad reputation at that time. Hence, dear colleagues, evaluation is very, very important to offer a successful treatment. And that is why the slide, which basically shows multiple doors, because you need to open the right door for the right patient. And you as ENT surgeons are very well qualified to open that and do that particular exercise. And in order to help you open the right door for the right patient, evaluation is the key. Now, once a patient walks into your clinic, the first thing that you would do, as in any kind of condition, is history and history and history. Now, what is important is there are a run-of-the-mill questions that any textbook would give you to that are, snoring, witnessed apneas, excessive daytime sleepiness, so on and so forth. But what you need to understand is that obstructive sleep apnea is something that shrouds itself differently to different people. For example, for us, ENTs, the patient would come to you with snoring. To a patient to a cardiologist, the patient would go on with a complaint of uncontrolled hypertension requiring more than 2 to 3 drugs. For a patient to a pulmonologist, the patient might present with type 2 respiratory failure, and for a neurologist, the patient might present with stroke. So it's very, very important that when a patient walks into your clinic, you need to extract and evaluate these patients very clearly and ask all these questions as well. Now, if these are the symptoms that a patient would have during the night, which is witnessed apnea, frequent nocturnal awakenings, dry mouth, nocturnal enuresis, and restless sleep, during the day, the most important symptom that you should ask is number 1, fatigue, 2, early morning headache, and for patients who have migraines, the frequency of the migraines become worse. Why does it become worse? Because obstructive sleep apnea has a lot of CO2 retention, causes CO2 retention in the body, and CO2 causes vasodilation, making migraine worse. One of the very commonest symptoms that patients come to us with is also falling asleep during driving. This is very, very common. Now, in addition to the stock questions that you would ask your patient, it is very important to also ask for history of insomnia, because insomnia is one of the commonest comorbidity of obstructive sleep apnea. When a patient has obstructive sleep apnea associated with insomnia, that condition is called COMISA. Now, insomnia, as you know, dear colleagues, is of 2 kinds: maintenance insomnia and initiation insomnia. Maintenance insomnia is what is more common with obstructive sleep apnea patients. So when you ask the patient, you should ask them, say, do you have problem getting into sleep or do you have problem maintaining sleep? And most of these patients with obstructive sleep apnea, maintenance insomnia. So that means they wake up multiple times because of either sleep fragmentation caused by oxygen desaturation, or a condition called very high arousal threshold. Nocturnal movement disorders are one of the second most commonest comorbidities that patients have with obstructive sleep apnea. You should ask for history of anemia, should ask for history of pregnancy wherein periodic limb movements and restless leg syndromes increase. So in restless leg syndrome, one of the commonest problem is reduced ferritin levels. So you need to check for ferritin levels as well. Alcohol is a drug that most of these patients keep taking and justifying themselves, saying that, doc, I take alcohol to put me to sleep so that I can have good sleep because I don't get sleep. This patient probably has initiation insomnia, and he also has obstructive sleep apnea. And because he's taking alcohol, he would get a lot of REM sleep. And all of you know that alcohol causes the quality of sleep to deteriorate, because apneas are more during REM sleep and the basic overall quality of sleep is going down. Medical history is also very, very important. Any painful illness can cause sleep disturbance. If a patient is having some other condition which is causing pain, will also have sleep disturbance. Any drug that they may be taking, any drug like a drug like SSRI, or a drug like amitriptyline, which is a tricyclic antidepressant, all of these can affect sleep quality. And all of this history is also very important. So when you take history, not only it is important that you ask the stock questions that I've described before, you also have to ask this history. Once you've asked history, it is very, very important to engage the patient. Once you ask them questionnaires to assess the severity of the disease, the patient also has a sense of belonging to you, and they also are very important. Now, I don't expect you to sit with the patient and answer these questions very patiently. It is important to see your other patients as well. So questionnaire not only help you to understand the severity of the disease from a patient perspective, the patient also feels a sense of belonging to you. And most of my patients come back and say, thank you for asking me the questions, doctor. You are the first person who actually understood my problem and trying to ask me the right questions. It's not you who's asking these questions. You don't have to reinvent the wheel. The questionnaires are already there. Now, again, there are lots of questionnaires that are available. I'm going to bring to you only a very few questionnaires that are important. The most important questionnaire that most of us ask during an obstructive sleep apnea evaluation is called Epworth Sleepiness Scale. Now, is Epworth Sleepiness Scale going to give you the sense of severity of an obstructive sleep apnea? No, it only gives you the patient's perspective that he's having excessive daytime sleepiness and the patient may have obstructive sleep apnea. So it's been Murray Jones, who actually belongs to Epworth. And this Epworth Hospital is in Melbourne. And he basically brought out this questionnaire, and it's named after the hospital. So this is a very, very simple questionnaire, and the patient would basically answer this questionnaire, and based on the score you give them, it gives you a sense of sleep fragmentation that the patient might be suffering during the night, and gives you an idea that the patient is having excessive daytime sleepiness. Please, colleagues, do you remember that this is not a scale to sort of gauge the severity of obstructive sleep apnea. It basically gives you the severity of the disease. This is a pictorial Epworth sleepiness scale, which also makes it a little interesting for the patient to sort of fill, and gives, again, a sense of belonging to you. Now, Stop Bank questionnaire is another questionnaire that most anesthesiologists use to screen patients for obstructive sleep apnea. Now, this predicts the risk of post-operative complications, and that is where anesthetists use this questionnaire pre-op to weed out these patients who are having obstructive sleep apnea. So Stop Bank questionnaire has a very high sensitivity to predict moderate to severe sleep apnea. That means if you were to have moderate obstructive sleep apnea, the Stop Bank questionnaire has an 87% sensitivity rate to pick up obstructive sleep apnea, which is moderate. This is the Stop Bank questionnaire. Stop, which is Stop Bank is an acronym for snoring, being tired, observed apnea, high blood pressure, which is stop. Bang basically means high body mass index more than 35, age older than 50 years, neck circumference more than 17, and gender being male. Now, Stop Bank questionnaire is basically being made for the Caucasian population. If your body mass index is more than 35 for an Indian, you are severely obese. And if you basically go only by this neck circumference of 17 and this BMI of 35, you are going to let out a lot of Indian patients, and you won't be able to pick up. Like I said before, Indian prevalence is quite high. So there's a beautiful paper by the anesthesiology department of St. John's, wherein they reduced the BMI to 30 and neck circumference to 15, and suddenly their pickup rate for obstructive sleep apnea patients became very, very high. So even in your practice, and you have to, if you are somebody who's practicing in the subcontinent, for us South Asians, you need to slightly tweak the body mass index to 30 and the neck circumference to 15. Now, once you have done the examination, once you're done with the questionnaires, the patient is now come back to you and is sitting in front of you and is handed over the questionnaire to you, and you've analyzed whether he's excessively sleepy, or you think that the patient is having moderate to severe obstructive sleep apnea based on your Stop Bank questionnaire. The proper evaluation of these patients would start. You have to start right from the nose, and you have to start from the nasal valve itself, because a lot of patients with obstructive sleep apnea have allergic rhinitis as a comorbidity. So you cannot just shove the scope into the nose and start doing the DNE, you have to assess the external nasal valve and the internal nasal valve, because evaluation of the nose is pivotal and primary in the management of obstructive sleep apnea. Why? Because the nose contributes to 50% of airway resistance. So while you do your assessment, what are the things that you need to assess? You need to assess the nasal valve, like I said before, the nasal septum, the turbinate hypertrophy, the adenoids and polyps, and not to forget the septal swell bodies. These are also very important, which are at the level of the middle meatus and the middle turbinate. Why is this important? Because based on the studies of computational fluid dynamics and based on CBCT findings, the middle meatus contributes to 75% of airflow, and hence assessment of septal swell bodies are also very important. This is also called as the septal turbinate, and that's how much resistance the septal swell body can impart to the nasal airway. It is also very important that you assess the patient's facial skeletal patterns. And based on this facial skeletal pattern, it is very important you would assess your patient to be a skeletal patient or a soft tissue patient. If you remember the video that I played of two different phenotypical patients, in the first video, there was a patient who's slightly on the obese side, and there is, on the second video, you had a patient which is on the skeletal side. So hence, it is, dear colleagues, it is very important that you assess your skeletal framework. It is also very important that you assess the diameter of the piriform aperture. Because if you look at a skeletal patient and somebody who's had adenoids and has been having mouth breathing since childhood, because of a high arched palate and because the maxilla has become very narrow, there is decrease in the transverse diameter of the maxilla. The piriform aperture becomes very narrow. So even though you do a beautiful septoturbinoplasty, the piriform aperture is very narrow. So even then, your airway will be having an obstruction. So it is important to assess the patient's piriform aperture on the CT. Malocclusions is something that is important that you as a sleep apnea surgeon has to assess, because dental malocclusions are very, very common in patients with sleep apnea. It's not necessary that you need to understand this. If you have a patient who's having a lot of skeletal, who's somebody who's having dental malocclusions, it is a red flag for you to think that this patient may be having a skeletal issue in terms of obstructive sleep apnea. Here are three examples of patients. This is a child, this is a teenager, and this is an adult. These patients actually come to you with obstructive sleep apnea. And just imagine, how will this tongue fit into this mouth? The tongue can only do three things in this particular patient. It can the tongue either has to come out, or the tongue has to sit inside the mouth, which this patient has no space for, or this tongue has to fall back into the airway during sleep. And hence, identifying these patients with high arched palates are very, very important. These are skeletal patients. Even if you do a good midline glossectomy in these patients in terms of management, you will not get a good result. Beware of that. So why is it that identifying the nose and identifying the dimensions of the nose very important? Because increased nasal airway resistance causes mouth breathing, and mouth breathing causes collapsibility of the upper airway, making the airway worse for obstructive sleep apnea. Assessing the nasal resistance is also very important. Nasal diameter is very important because even if you give a CPAP to this patient, because of increased nasal airway resistance, your CPAP patients will reject CPAP in the first instance. So if you want to make the CPAP very effective to your patients, you have to reduce the pressure with which the CPAP is delivering air into the body. If there is significant nasal airway resistance because of a high arched palate, because of a septal swell body, because of large concha bullosas, because of adenoids, the CPAP will not be successful. And literature tells us that the CPAP acceptance is best if their experience with CPAP is great in the first few days. And if the nasal resistance is too high and the CPAP pressure is going so high that the patient's mask is jumping out of the patient's face, the patient will not accept CPAP. And hence, our sleep apnea, the physicians who treat sleep apnea, whether it is pulmonologists or dental colleagues who are involved in the management of obstructive sleep apnea, has to send the patients to an ENT to assess the nasal component. Now, at this point, I would like to bring in a lot of classifications we as sleep apnea surgeons use in the management of obstructive sleep apnea. Now, the commonest or the basic classification that we used to use in the 90s and the early 2000s is the Fujita classification. Why did I say the historical classification? Because we don't use this anymore. Because for us as ENT surgeons or dental doctors who are in this forum, for you, type 1 collapse means palatal collapse means nothing. Because for you as an ENT surgeon, you need to know what is the structure causing the problem, what is the severity of obstruction, what is the pattern of obstruction. So if you say combined obstruction on the palate and hypopharynx means nothing. And hence, we don't use Fujita classification anymore. Friedman classification we still use today. Why? That is because it gives us a sense of success of soft tissue procedures in the outpatient. So the general tone when you talk to your patients will automatically change the moment you look at this kind or this kind of airway. Now, these kind of classifications are nothing but Mallampati classifications. When you combine Mallampati classification with the tongue inside, with the Brodsky's tongue classification, you get the Friedman classification. Now, why is this classification very important even today in 2022? Because it gives the success rate of any kind of a soft tissue procedure. So if you were to have a stage 1 patient with a situation where the patient opens his mouth, you're seeing big tonsils, relatively enlarged tonsils with big fat palates, and the BMI is very less than 40, your success rate of this particular patient is quite high. So you will have a smile on your face. But unfortunately, patients don't come to you only with stage 1 or stage 2. Patients can come with all kinds of stages. And Friedman staging doesn't tell you what to do for stage 2 patients and stage 3 patients and stage 4 patients. That is why when you assess these patients and decide what to do for these patients just based on Friedman classification, you are at loss because patients don't come with stickers saying that I am stage 1. They are a mixed bag and they come with all stages of classification. Another classification which is brought out by Tucker Woodson is what we call as palatal phenotype. Palatal phenotype for you as sleep apnea surgeon is very, very important to analyze because If your patient is an oblique phenotype patient, that means once you put a scope at the posterior end of the nose and you have a nice sliding palate, you call this a oblique palate because the distance between the posterior end of the hard palate and the posterior pharyngeal wall is more. So no matter what you play around with the palate, you will succeed. As opposed to this patient, wherein the distance between the posterior end of the maxilla and the posterior pharyngeal wall is very less. These patients are called vertically oriented palatal phenotypes. So these are skeletal patients. These are soft tissue patients. These are skeletal patients. So you need to very clearly understand right in the outpatient department when you pass a scope wherein you are able to see the palate which is dropping down like a nice slide, or your palate is dropping down like a drape. Each one of them will give you insights into whether your patient is going to succeed with soft tissue surgery or with bony surgery. Morse classification gives you ideas in terms of whether it is a patient having what kind of tongue base collapse, a high tongue base, and a low tongue base, or an epiglottic collapse. What is also very important is a classification called Chronic-Lehan classification, which tells you as an ENT surgeon the difficulty to intubate. Hence, you will be able to plan the post-op plan for this particular patient. As you can see, if a patient is grade 1 Chronic-Lehan, the chance of having difficult intubation is less than 1%. Most of your patients would have, your run-of-the-mill patients will have Chronic-Lehan 1. Very rarely you would have a very, very difficult intubation, which is grade 4. Neither glottis nor epiglottis is seen. These kind of patients, if you want to intubate, it's going to be very difficult. So you need to have some kind of a CMAC or a device which can help you to intubate, or it is better to tracheostomize these particular patients. Hence, understanding a modified Chronic-Lehan is very important. Now, once you are done with the classifications, it is important to assess a flexible laryngopharyngoscopy. Now, earlier, we used to do a maneuver called Muller's maneuver, wherein you put the flexible scope inside and ask the patient to take a deep breath and do a Valsalva, which would give you an insight into how compliant or how collapsible the upper airway is. But with this kind of a with this kind of a classification, which is the Muller's maneuver, you will not be able to get much of an understanding of the upper airway. Now, you would almost always ask me, how do you assess the severity of the disease? Now, to assess the severity of the disease, one needs to understand what is called as polysomnography, because polysomnography gives you the need for treatment and the urgency for treatment. This is the pathophysiology, dear colleagues. Now, whatever you do in terms of analysis, whether you do a questionnaire, you do a flexible laryngopharyngoscopy, you do a dental analysis, it will not still give you the impact in terms of oxygen desaturation or sleep fragmentation. In order to understand the severity of the disease, you need to still do a polysomnography. Now, based on the type of study, they have different names. The level 1 study is a fully attended study with typically about 7 parameters on 21 channels you can record. Now, when do you do a level 1 study? A person has lots of comorbidities. It is better to do an in-lab study. When do you do a level 2 study? A level 2 study in the first place is everything that a level 1 study does, except that you're not doing it in a sleep lab. So if you have a patient who has problems in terms of CO2 retention, or if you think that the patient has central sleep apnea, it's better you do level 1 study. If you have a patient taking multiple drugs for hypertension, if you have a patient having chronic bronchitis, if a patient is taking medicine for epilepsy, it's better you do a level 2 study at least. But if you have a patient who's classical of obstructive sleep apnea, if you think that the patient has no comorbidities, you can do a level 3 study, which is basically just a cardiorespiratory kind of a study. And it still does not give you an assessment of the depth of sleep. Now, where level 2 and level 1 score is, for example, if a patient has 20 apneic episodes, which your level 3 has picked up, level 3 still does not tell you whether all those apneic episodes happened during LEM or all those apneic episodes happened between in REM or non-REM. So it is important that you analyze that as well. So if you have a patient having comorbidities, do a level 2 or level 1. If a patient has no comorbidities, you can do a level 3 at least. Do not use level 4 as a simple pulse oximetry or something like that to assess sleep apnea. The minimum you have to do is level 3. So once you have a level a sleep study in front of you, these are all the metrics of measure that you need to look at. Sudeep, how are we doing with time?
Yeah, we're good, sir. Kishore, we're fine. No problem.
No problem,
yeah,
right?
We're good.
So once you do a sleep study, you need to assess these parameters. The first one that you need to assess is what is called a sleep efficiency. Sleep efficiency is the first thing that you see in this sleep report. If your sleep efficiency is less than 85%, that means the sleep study has not been done properly. Please repeat the sleep study again. Now, sleep efficiency is something that you will not be able to get on a level 3 report. So you can ignore that. The second thing that you need to look at is what is called as sleep architecture. What is sleep architecture? Sleep architecture is a metric of measure that tells you how the patient is faring in terms of the quality of sleep. How much time the patient is spending in N2? How much time is the patient spending in N3? How much time is the patient spending in REM? At what onset time did the patient enter REM sleep? All of this is called sleep architecture. So if a patient has sleep fragmentation and destruction of sleep architecture, that means for some reason the patient's either having destruction of sleep architecture because of oxygen not going in properly, or the patient has another kind of sleep disorder. Dear colleagues, please remember, everybody may not have sleep-related breathing disorders. They may have some kind of sleep disorder associated with a sleep-related breathing disorder, and hence analysis of sleep architecture is very important. The next metric of measure is called apneic hypopneic index or respiratory disturbance index. So you need to look at apneic hypopneic index. That gives you the severity of the disease, and you also have to look at the postural variation. That means you need to look at AHI in supine and you have to look at it in non-supine. The other measures that most important people have to understand is the ODI. ODI is a metric of measure that is directly proportional to the oxidative stress. That means oxidative stress is directly proportionate to end organ damage. The oxidative stress is directly proportionate to cardiovascular morbidity. LSAT, which is the metric of measure that most of us see in the sleep study, is also important because that, along with ODI, along with the next metric of measure that I'm going to talk about, that is T90, or the time spent below 90% saturation. These three measures are directly proportionate to end organ damage, whether it is cardiovascular or neurological. Snoring is another metric of measure that you need to look at in sleep study. And if you are looking at a type 3 or a level 3 sleep study, another measure that you need to look at is what is called as flow limitation. Flow limitation with snoring, flow limitation without snoring. If somebody has flow limitations without snoring, you need to understand that this patient has a lot of nasal airway resistance. Now, I have a couple of reports that I have, which I will talk to you at the end of the talk so that we can discuss. If time permits, we'll discuss each of these reports for you to understand. Now, if sleep study gives you the need for treatment and the urgency for treatment, for surgical planning, the sleep study does not give you anything. The sleep study only tells you how sick your patient is, but it doesn't tell you what to do as a surgeon. In order to select the correct procedure for the correct patient, you need to do surgical planning. And surgical planning depends on is a pyramid which has three primary prongs. One is you need to select whether your patient is a global patient. That means the patient is having sleep apnea because of obesity, or a local patient. Here you can see the tongue and you can see huge tonsils. This is a low-lying fruit that you can pick up, and straight away you are going to decrease the disease burden and you're going to give success. You need to understand if your patient is a soft tissue patient or a skeletal patient. And you need to differentiate which are all the static obstructions and which are all the dynamic obstructions. These three-pronged philosophy is very, very important to structurally identify and have an algorithm to take your patient further in the management of in the surgical management of OSA. These are few examples of static obstructions. This is an adult patient with huge adenoids. Most of our patients have very bad laryngopharyngeal reflux causing adenoids. This is an 18-year-old patient who was given CPAP because nobody put in a scope to see why this patient was having obstructive sleep apnea, and there was a huge lipoma sitting on the laryngeal inlet. If those are static obstructions, these are dynamic obstructions with which the patients also present with. So we need to understand our static patients with our dynamic patients. Now, there are very many ways of assessing the a dynamic assessment of the upper airway during awakening and sleep. None other than the most important study, which is drug-induced sleep endoscopy. Since we can't get into people's bedrooms with the endoscope, and it's very difficult for patients to stay still and maintain their depth of sleep if you put in a scope through their nose. And for us as ENT surgeons, it is very important to understand the behavior of the upper airway during sleep. With the goal of reproducing the upper airway behavior during sleep, drug-induced sleep endoscopy came into vogue in the 1990s. First done by Pringle and Croft in the 1990s. Then it sort of lost flavor. Now again, it has almost become a gold standard for us as surgeons in the management of obstructive sleep apnea. Now, there are many drugs that are there in the armamentarium for an ENT surgeon. None more important than dexmedetomidine and propofol. Now, when you do a drug-induced sleep endoscopy, it's not a FLP that the patient is getting done. You need to understand that PAC is very important for these patients. It is also very important that you do the drug-induced sleep endoscopy in at least an endoscopy suite, or it is best done in the operating room where there is a facility for measuring ECG, blood pressure, pulse oximetry, and in case the patient desaturates, there is a possibility to administer oxygen. But that does not mean that you should give oxygen the moment the oxygen saturation falls, because this patient is having repeated oxygen desaturations every night. So let the oxygen fall to the level up to the lowest oxygen saturation. So if somebody has a bispectral index scoring machine in the operating room, that suggests that gives you the depth of sedation, that's excellent. So this is the different drugs that one can use in terms of the sedation modalities, all with pharmacokinetics. This is something you can take on. The most important drugs that we use today are propofol and dexmedetomidine, each one of them having their own advantages and disadvantages. And this is the machine that you use, and this is what you see as when you see as an ENT surgeon. Now, once you do the drug-induced sleep endoscopy, you need to evaluate the drug-induced sleep endoscopy and score it. And the commonest classification that we use throughout the world is the VOTE classification, or you can also use the NOHL classification, which is very common and popular in Europe. So in VOTE classification, the classification in the acronym are velum, oropharynx, tongue base, and epiglottis. We see a lot of reports coming from different places writing 100% collapse, 50% collapse. You cannot copy paste Cotton Mayer's classification into VOTE classification and just write a written document. It speaks volumes about the kind of report that you're giving. Please either use VOTE classification or NOHL, and this is how you're supposed to write a report. If there is no obstruction, you write 0. If there is partial obstruction, 50 to 75%, write 1. And if there is a complete obstruction, you write 2, so on and so forth. So this is how you can give a DICE report. So here are some examples for you. Here you are seeing, supposing we are doing a VOTE classification here. What will this become? V is 2, complete obstruction, and this is a lateral obstruction happening at the level of the velum. So we call it V2 lateral. So once this is done, at every level, you need to wait for at least 2 spells. That means here I waited for more than 2, but you have beyond, once you cross a particular level from velum to oropharynx, once you're going from one level to other level, you have to see at least 2 spells. Now we are going into the oropharynx. Here you see that the oropharynx is not closing, so you give a score of 1. Next is T in the acronym. Is the tongue base collapsing? No. That means you give a tongue 0. But what else is collapsing below? The epiglottis is collapsing here. So you give an epiglottis lateral and you give a 2. And that is how you have to score a DICE report. Here is another DICE report wherein you're seeing an obstruction happening here, and you are seeing at least for 2 cycles. Now we're going into the oropharynx, and you can see how the lateral is collapsing. Now you should also look at how the larynx is. It's important because having a supraglottic collapse is a bad prognostic factor. Now, sometimes we also do what is called as interventional DISE, especially for mouth breathers. Because, see, this patient's tongue seems to be collapsing. And if you were to look from the nose and go down, you would think that it is a tongue-based collapse causing obstruction. But if you see here and go through the mouth, you will see because of the tongue not being able to sit in the oral cavity, the tongue is falling back and causing a obstruction. See how the tongue is going back and causing obstruction. We also do what is called as interventional DISE, wherein you put in a nasopharyngeal airway, mimic a nasal and soft tissue surgery, and see if the lower hypopharyngeal collapse is clearing off. As you can very clearly see in this patient, as long as the tube is there, the airway is remaining patent. But the moment you take the tube off, you can actually see that the whole airway is collapsing. So this basic test is telling us that whether you do, even if you do a very beautiful palatal surgery and a nasal surgery, this patient is going to fail. And this is how DISE can prognosticate your success rate. Your positioning is also very important. This is a chapter I've written in the drug-induced sleep endoscopy textbook about the importance of head trunk position, and it's also very important that you put the head in different positions to analyze if you can suggest this to your patient during sleep to clear their apneic spells. Herein, we are doing a DISE with polysomnography, and this is called advanced DISE. As you can see, that the patient is asleep, and here the patient is getting the sleep study, and here we are doing the DISE. So here we are actually bringing in the sleep study and sleep endoscopy together to validate the seriousness of the situation. Dynamic MR is something that you can also do, but it's very difficult for patients to sleep in a MRI gantry and get it. So my experience with MRI is very less. So there are some sleep case scenarios, but for wanting time, I think I will skip all this and basically come to the final slide, which is to know even one life has breathed easier because you have lived. That is to have succeeded, as said by Ralph Waldo Emerson. Dear ENT colleagues, to know even one of your patients has breathed easier because you have done what is right for that patient, that gives you success. With this slide, I would like to say thank you for the opportunity, and I would be happy to take any questions if they are.
Thank you, Kishore. Thank you, Kishore, for a wonderful presentation.
Thank you very much. Let me just stop the... 1 second. Stop sharing, yes. Sorry, I must have gone overboard, but you'll have to excuse me. Sometimes, you know, I may just get carried away, but I'm very happy to take any questions.
Right, Kishore, you're on time.
Thank you.
I think with the death of Gopi Lahari, I think this OSA has become
this has
big
become
talk of the town.
Yes. A lot of people are coming here and asking, you know, evaluation for. See, us as ENT surgeons, I mean, we are very, very well poised. You know, we can also give CPAP. We can also find out why the patient is not able to give the CPAP, tolerate CPAP. And we are also in a very unique position to correct any abnormality that is there in the airway to make CPAP acceptance better. And if the patient fails CPAP,
Hello,
there
sir.
are techniques we can do.
Hello, sir.
Hello.
Yes, sir. I'm from Kolkata.
Yes, doctor, please tell me.
As you have mentioned the use for anesthetic agents like propofol in
Yes.
DICE.
Yes.
So what about the propofol allergy in some case?
Yes, as you correctly said, propofol can be, people do get drug allergies because it's made of protein and it's milk based. So most of these patients actually get a skin prick test before inducing propofol. So you can, if you are scared of such a reaction, you can always use dexmedetomidine.
In that case, the procedure would be smooth enough to do DICE.
Yes, you can use dexmedetomidine instead of propofol.
Okay.
The advantage of dexmedetomidine is that it does not cause respiratory center depression and it maintains sleep architecture. But the biggest problem with dexmedetomidine is that it takes a lot of time to induce sleep. So in a busy OT, and if you are in a busy hospital, your anesthetist will be in a rush to give that OT to somebody else. So he will not have the patience to sit with you till the sleep is induced. So, but one trick there is while you give the infusion of dexmedetomidine, you can also give bolus doses of dexmedetomidine, keeping the heart rate in picture. But again, if a patient is on beta blockers for his control of blood pressure, please remember that this will cause further reduction of heart rate and you might land up with a disaster. So always do these sleep endoscopies with the anesthetist.
Oh, thank you, sir.
Thank you. Good evening, Ramesh.
Sir, thank you, sir. Thank you so much, sir. Sir, one
Sure.
question
So
from audience, sir. They're asking
one study actually.
sleep study report, sir. How to interpret sleep study report?
Oh, sure. Shall we go back then? We'll take the scenarios then.
Yes, sir.
Okay.
In those case scenarios, we will be able to. One second. One second. I'm just not able to find this. Yeah, it should be here only. I will stop sharing once. Are you seeing the screen? You're not seeing anything, right? You must be seeing me.
Yes, Kishore.
One second.
Yeah.
You're able to see now?
Where, Kishore? No.
Are you able to see my slide?
No,
No?
Kishore. No.
No. One second. Let me just. It says Microsoft PowerPoint 2, but I'm not able to.
Harsha here, any problem, sir?
Just 1 second. I mean, I'm not able to open this. So let me just share. Has it come now?
Yes, sir, your PPT is visible.
Oh, it's come, no? So let me just go to. I'll just sort it out and I'll go with case scenarios. Yeah. Are you getting it?
Yeah, almost here, almost there actually. Kishore.
No, so case scenario. Slideshow. Okay. Are you getting it now? Sudeep?
Yeah, no, no, case scenarios, we can see the.
Oh, you can see the slide, right?
We can still see the slide, but not only the name of case
Okay.
scenarios.
Yeah, sure. So now you're seeing
Yeah,
case
got it.
one?
Yeah.
Yeah. So reading the sleep report also will come into this. So case one, here we go. So he's 26-year-old male patient with a BMI of about 24 with an Epworth sleepiness scale of 15. So that means the patient is having excessive daytime sleepiness. His BMI is 34. That means he is in the obese category. He's only 26 years old and he's a male. On ENT exam, he has a deviated nasal septum. He has turbinate hypertrophy. His tonsils are Brodsky's grade 3. FTP is 2. So once this is done, FTP means Friedman tongue position 2. In Friedman tongue position 2, what happens? You can see the tonsils. You can see the soft palate. You can see from the, you cannot see the tip of the uvula, but you can see the base of the uvula. You can see the fascial pillars as well. Okay. With that kind of an ENT exam, the next thing what you will do a sleep study. Now, in the sleep study, the moment you get the sleep study, the first page will have these values. Okay. Now, if you see, the sleep study is again divided into REM, non-REM, and TST. That means total sleep time. So this particular patient on that particular night did not have any REM sleep. So his AHI, which stands for Apnea Hypopnea Index, is 84. And since he didn't have REM sleep, the total value becomes 84. Right? Now, what does Apnea Hypopnea Index mean? Apnea means absolute cessation of breathing at the nose and mouth for 10 seconds. Right? Now, hypopnea means 50% reduction of airflow at the nose and mouth with a 4% reduction in oxygen saturation. So this value is a combination of all the apneas happening and all the hypopneas happening for 10 seconds. So if this person is having an apnea hypopnea index of 84, that means 84 into 10 seconds. That means 840 seconds per hour this patient is not breathing. Now, the other value below is called RDI, means Respiratory Disturbance Index. Now, what is RDI? Like I said, apnea is absolute blockage. Hypopnea is 50% reduction. RDI involves another metric of measure called RERA. Okay, RERA means respiration evoked repeated arousals, which were not there in this patient. Hence, the value remained the same as AHI. Once you look at these particular value, you know based on your finding that this patient is having severe obstructive sleep apnea. Why severe? Because AHI of 5 to 15 is mild, 15 to 30 is moderate, and more than 30 is severe. So this patient is having severe obstructive sleep apnea. at age of 26. Now, the next value you will be looking at is oxygen saturation. So the mean oxygen saturation for this patient is 76 that day night. And the minimum value is 47. Can you just imagine this patient is having a very, very bad oxygen saturation of 47. So you know already that his AHI is 84, his lowest oxygen saturation is 47, and his snoring levels are 821. So you already know that this patient is quite bad. Next values that you'll be looking at is whether this patient is having all central episodes or all obstructive episodes. So if you see, if this patient is having more than 50% of the obstructive episodes, then the central apnea is significant. Here, you are having central apneas, but when compared to the number of obstructive apneas, this is hardly any. So the central apneas are of no value. The next important thing that you need to look at is at each stage of sleep, how many desaturations or how many apneas this patient is having, right? So nowadays, you don't get these S2, S3, S4 values. You just get N1, N2, and N3. But that's okay. Just for you to understand, again, telling us this patient didn't have any REM sleep, but this patient had slept for about 203 minutes in N2 sleep or S2 sleep. And this patient had decent sleep. That means this patient's sleep architecture is pretty okay. This is called a night hypnogram, which basically tells us whether the patient had deep, significant sleep fragmentations because of this oxygen going down. But you see, there are not too many skyscrapers. That means the patient slept pretty well. The patient did have microarousals, but the patient did not have awakenings, right? The snoring was there throughout the night, and this gives position, whether it is right side or left side or back. And you've seen that patient was having significant desaturations. So with that kind of a sleep study, we will do the sleep endoscopy. Now, if you look at this patient's sleep endoscopy, you see huge salpingopharyngeal folds. Let us, I'll let the video run. You're in the nasopharynx now. Now, lots of secretions are there. I am, for one, I'm not in favor of giving glycopyrrolate because giving glycopyrrolate affects the heart rate, and hence that's why I don't do that. We are at the level of the, see how low the palate is, almost touching the epiglottis. See, the entire airway is blocked. Now again, you're coming back. See how even on the top, these salpingopharyngeal folds are touching and causing an obstruction. The patient is having severe, imagine the intrathoracic negative pressure that this patient might be really creating. For a normal human being, right, the intrathoracic negative pressure that you should be generating is only maximum 8 to 10 to 15 centimeters of water pressure. When somebody has this kind of anatomy, what happens is the patient would generate 50-60 amount of negative pressure, and hence significant amount of reflux because of the intrathoracic negative pressure. So again, I'm having a go at this and just trying to analyze, see how big the salpingopharyngeal folds are. This is eustachian tube. See, even before the soft palate is touching the posterior pharyngeal wall, the salpingopharyngeal folds themselves are causing an obstruction. And this is a complete obstruction here. So what was the treatment plan that we did for this patient? The next question was, what are the procedures that you would plan for this particular patient? Would you stage them or no? So since it can be two ways, this is a case scenario. If anybody volunteers to answer these questions, that's well and good. Otherwise, I will answer it. Are there any volunteers, or shall I answer them? Would anybody come forward? That's fine. So the treatment plan for this patient was, remember the BMI, it's pretty high. But this patient had significantly, look at his, oh, 1 second. He had grade 3 tonsils. He had a favorable palate. So even though and the dice told us that there is a lot of tissue redundancy, and doing a good soft tissue procedure, because with so much of obstruction, even if you give him a CPAP, the pressure with which the CPAP would go inside would be very, very high. So the patient may or may not accept it. So what we did for this patient was salpingopharyngeal channeling. We did a combination of expansion sphincter pharyngoplasty and anterior palatoplasty, and we actually did because you saw that there's not too much of a tongue base coming into view, just doing a good nasal procedure, doing a modification of UPB procedure actually helped the patient quite a bit. And then the patient lost weight, his BMI went down, and now he's doing well. This is one kind of patient. Case 2 is a patient who's 26-year-old young guy who had snoring as his primary symptom, fatigue, excessive daytime sleepiness. These are very, very common symptoms that patients are coming nowadays. You are not getting these run-of-the-mill big fat patients anymore. These are patients with BMIs of 23, 24 with a very high Epworth sleepiness scale. So if you do the sleep study is moderate sleep apnea. But would you ignore these symptoms of snoring, fatigue? So what I want you to understand is AHI just gives you oximetry values. It does not tell how sleepy this patient is and the impact that this patient is having in terms of sleep fragmentation and the neurobehavioral discomfort that this patient is actually having. So dear colleagues, don't go just by the sleep report. The sleep report just gives you the severity of problem in terms of oxidative stress. It does not give you the impact that this condition is having on the person's neurobehavioral architecture, sleep fragmentation, and neurobehavioral side effects. Look at this. Patient's main symptom is fatigue. Main symptom is excessive daytime sleepiness and Epworth sleepiness scale. Now, if this patient were to go to a pulmonologist, would they give a CPAP? No, they won't, because the AHI is 14. And even though the patient is having snoring, they may give you an option of using a CPAP. Now, would this patient, a 26-year-old, use a CPAP, having an active lifestyle? He may or may not have gotten married. He may have an active lifestyle. And if he is somebody who's roaming around with a CPAP, this is something that the patient doesn't want. So in the sleep study, the patient's lowest oxygen saturation was 84. So the longest oxygen saturation was 88%. The minimum SpO2 value was 83. The minimum SpO2 value was for a duration of 1 second. So that is also very important. LSAT itself is not is important, but how long the LSAT was is also very important. That shows that how effective the body system is in waking up the patient multiple times in the middle of the night. The body is not allowing the patient to take the oxygen below 83. So patient is having multiple sleep fragmentations, and you can see how many arousals this patient had. See, he didn't have an actual arousal, but look at all the micro arousals this patient had. That is why this patient is having more daytime sleepiness symptoms and having fatigue. Look at the SpO2, pretty good. But would you not treat this patient because the patient's oxygen saturation levels have been maintained throughout the night? No. This patient is having severe neurobehavioral issues. With the Epworth sleepiness scale, he has scored for himself is 18. It's pretty high. So what is the DICE of this particular patient? You see the color difference here? You look at the tubal tonsil. You see this color, very typical of reflux that happens because of. So this is another patient. So on a DICE, would it be a 2 or a 1? It will be a 1. Okay. And what is happening at the level of the velum? The velum is 1 and it is lateral. Now, when we go down into the throat, you see what is happening to the oropharynx? Oropharynx is also a 1. It's not completely blocking, but since the airway is very compliant and it is collapsing, the lung has to work hard to get air through that narrow opening, right? So this is a wonderful case. See, the tongue base is not really collapsing. The epiglottis is not really collapsing. So this is a very good case. So this is what, if you look at word classification, V is 1 lateral, O is 1 lateral, T is 0, E is 0. This is an excellent case for a surgical intervention. So what would be the management protocol? Yes, since this patient had a lot of coexisting reflux, you have to start the patient on PPIs because we don't want a patient to be refluxing when you have an upper airway surgery in that area. That would cause superadded infections and can cause wound dehiscence. The procedures you would perform in this particular patient are expansion sphincter pharyngoplasty, which is a procedure which is beyond the scope of this lecture because each one of them is a different lecture by itself. But wherein you're using the palatopharyngeal muscle and repositioning it in the level of the I will talk to you about each of the DICE findings and what kind of matching soft tissue procedures you need to do. That's for another time. And we did a good soft palate, soft tissue procedure and a good nasal procedure, and the patient is doing well. This is another patient. The reason why I put the face is I want you to appreciate the way the face is. Look at the face. It's vertically oriented. We call this a dolichocephalic phase. He's a male patient with a BMI of 25. Again, Epworth Sleepiness Scale 18. AHI this time of 62 and LSAT of 86. And a soft tissue procedure has been done twice. See now again, if you look at the hypnogram, multiple arousals. He didn't wake up, but arousals, micro arousals. Look at all the apneas, look at all the hypopneas, look at all the desaturations that were happening. Look at the snorings and look at the heartbeat variations. Look at the leg movement. His patient is thrashing. And look at the sleep positions. No matter in what position the patient is having sleep fragmentation and oxygen desaturation. So if you look at this patient's DICE, see the patient is opening the mouth and now we are going through the nose. See how the palate is now falling in an anteroposterior way. The earlier two dices you've seen that the palate was going side to side in a lateral way. You see how the palate is on a AP direction. So this would have actually become an velum AP2, correct? Because it's a complete collapse and it is an anterior posterior collapse happening at the level of the palate. Now we are crossing all that obstruction. I am trying to go inside and see why and what is happening. Okay, this is a complete collapse. Just wait. I will let the video run for you. Ignore the post-nasal drip. The patient is asleep. The patient is trying to make an effort. The patient is in apnea right now. So now the airway is opened up. There was one snore and again the patient went into apnea. All that is apnea. With just not able to bypass the soft palate. It is so thick and it's fallen backwards. We're not able to make out what each of these structures are. We've reached somewhere, but we are still not able to make out where we are. So now we are able to make out. Where are we? We are in the hypopharynx. See, and you can see how the tongue is causing an obstruction to the one thing you must be very clear. Now see how anteroposterior, the earlier two videos were lateral. Now you can see how the tongue is coming and causing a secondary epiglottic collapse. See how the tongue is falling back? And this is called a secondary epiglottic collapse. You can very clearly see how the tongue is falling backwards. So what kind of a So now that he's been operated twice before and he's non-CPAP compliant and he's having severe oxidative stress, severe apneic hypopneic index, severe ODI, how do we manage this patient? Basically, this is a skeletal patient. The soft, because if you would have observed the beginning of the video, you see how the mouth is open, and this is called loss of tongue palate coupling. Because this patient has a very high arched palate, the tongue is unable to fit in the oral cavity, hence it is falling backwards. And the tongue falling backwards is actually falling on the palate and also causing secondary palatal obstruction and secondary epiglottic obstruction. The tongue is the problem here. But why is the tongue falling? Is the tongue falling because of the size of the tongue? No. The BMI of the patient is 24. He's not fat at all. The problem here, dear colleagues, is relative macroglossia. Because the skeleton, the size of the container is small, the tongue appears big, and hence it's falling backwards and causing a problem. So what do? We do what is called as a maxillo-mandibular advancement, wherein we make the box bigger. So here you can see we do a Leafort 1 and we bring the upper jaw forward and we do a BSSO, it's called bilateral sagittal split osteotomy, and slide genioplasty, and we bring the jaw forward by 1 centimeter, increasing the space thereby. And this procedure is called maxillo-mandibular advancement. This procedure has the highest success rate amongst OSA procedures, with a success rate equal to, if not better, to CPAP. Okay, I'm done.
Thank you, sir. Thank you, Kishore.
Thank you very much.
Yeah.
Let me just
excellent
let me stop. Let me expand this and yeah, I'll stop sharing. We can actually have like a separate session on sleep studies itself, different levels of sleep study and what each sleep study will explain and what are the measures that we need to see. And that also can be done in a separate session if time permits. That's not a problem. So
thank you.
Thank you very much. Thank you for having me and for your patient listening.
Oh, it's an excellent presentation, Kishore. Like your presentation.
Thank you very much.
Thank you for your time, sir.
So thank you, guys. Thank you for having me.
Sir, program, sir.
I can't hear you.
Sir, our next month programs.
Yes.
Can you announce now itself?
About yeah, sure. I would like to take this opportunity to sort of let you know that we are running a dedicated. It's a pediatric ENT update. We're calling it update on pediatric ENT, wherein we are going to focus only on the regular pediatric ENT problems. That is pediatric OSA, pediatric rhinitis and sinusitis, pediatric stridor, pediatric neck masses, and pediatric otology, both implant and non-implant otology. So each one is going to be for 1 hour, wherein we are dividing it into 15 minutes of lecture and 45 minutes of panel discussion, wherein the moderator will be an ENT surgeon, but the panelists will be 2 ENT surgeons and 2 pediatricians, so that we will understand their perspective and we can put our point across So it is going to be on the 24th of April. And it is going to be under the aegis of AOI Telangana and AOI Hyderabad and Indian Academy of Pediatricians Twin Cities branch. And it is going to be a physical meeting at AIG Auditorium in Gachibowli.
Thank you so much, sir.
Thank you, Kishore. Thank you
for agreeing to sort of do it under the banner of AOI Telangana. Thank you.
Pleasure, Kishore. Thank you so much. Good night.
Good night.
Good night, sir.
Thank you.
Nice
Good
time.
night.
Thank you, Harsha, for coordination.
Thank you, Harsha.
Thank you,
Thank you
Harsha.
so much, Harsha.
Bye, Sudhir.